metabolic stress and critical illness. Yay. All right, so the big picture with metabolic stress and critical illness is that there is a lot of inflammation happening, and there's that inflammation causes changes to hormone secretion, metabolism, all of these things that not only affect the patient's ability to heal, but also their nutritional status. So there are very significant nuances to nutrition care for the patients who have critical illness and metabolic stress. What do you think of when you hear metabolic stress, critical illness? Like what type of condition?
I'm the fatty liver disease.
Okay. So what I want you to set this up as is something much more acute and severe. Okay. So like fatty liver disease, that's a chronic condition. Can we have an acute injury or something in somebody who has fatty liver disease? Absolutely. Okay. Hyperthyroidism. Yes, that there's metabolic changes that happen with hyperthyroidism, but that's not an acute injury that's causing this inflammatory cascade, this change in hormones, metabolism, and all that. So think of like trauma, burns, sepsis, okay? The big bad stuff that puts people in the critical care unit, okay? So connect ICU, critical care with metabolic stress and critical illness. So these are people that have really, really significant acute injury, trauma, infection that is leading to systemic problems that cause metabolic changes that are affecting the whole body. All right. So that's why the nutrition support is so nuanced, because not only are we trying to adequately feed the patient, but we're trying to feed the patient appropriately when they're hemodynamically unstable, meaning that their blood pressure is not stable. Okay. They might have hypotension, high blood pressure, which is they might have hypotension 1 minute, high blood pressure the next minute kind of thing. Cardiac arrhythmias are common. They might have this element of respiratory distress that we just talked about last chapter. So a lot has to go into that. And when we're working in critical care, we have to really think big and critically think and consider all of the conditions that are affecting this patient's nutrition care. Thankfully, we have the Aspen Critical Care Guidelines, which you and I have actually looked at before. We'll look at it again probably on Tuesday. But for the novice dietitian, those are like a Bible. So if you have a patient and you're not really sure what to do with them, there are very black and white criteria for how you provide nutrition support to that patient with burns or acute pancreatitis or something like that. Okay. All right. So when we have metabolic stress, we have to think at the cellular level that things are going wrong. Tissue damage has occurred. What are our tissues made of? Cells. Okay. Organs are made of tissues. Tissues are made of cells. All right. So whenever we have trauma, that trauma leads to damage. All right. And that damage means that there's going to be cellular dysfunction. All right. What's the job of cells? There's multiple. Okay. We spent a whole 2 semesters in 411 and 412 talking about metabolism, energy production. Okay, so our cells not only are in charge of energy production, but they're in charge of like making everything that tissue needs, that area of the body, that organ needs. So maybe we can't build proteins, maybe we can't secrete hormones appropriately. All of these things. Okay. So when our cells are damaged, they have an inability to perform their normal function, but they also have a reduced ability of maintenance in their cell. Okay, so toxins can build up, byproducts can build up. Like the custodian in the cell can't do its own job.
This is like an old question, but like what happens when somebody has like an organ like gets deteriorating?
Same thing.
Same thing?
Yeah, you're on the right track. Yeah.
Yeah.
So like if somebody had necrosis of an organ or whatever, same situation is happening. We're having actual cell damage, cell loss. So the changes that we can see with the cells can be accumulation of bad stuff within the cell that can cause further inflammation and damage. We can have a reduced number of cells. The cell shape can be malformed. The cell size can be malformed. And all of this is going to promote and sustain inflammatory responses. Now, the one thing that we need to know from a metabolic standpoint is that anytime inflammation is present, metabolism isn't going to happen as like intended. Okay. Think of like normal metabolism, homeostasis being like this just like happy midpoint that our cells are always trying to achieve. But when we have inflammation, whether that's acute inflammation or chronic inflammation, that happy midpoint is really difficult for a cell to maintain. Okay. So give me some examples of chronic inflammation. I think of a really easy one. Like if somebody has chronic hyperglycemia, uncontrolled blood sugar, uncontrolled diabetes, that's going to put some inflammatory stress on cells, okay? So not only is our blood sugar consistently high, we're seeing inflammation in the cell, and that is going to further dampen metabolism or further hinder metabolism. Now, in a critical illness perspective, this inflammation is more of an acute response to some sort of injury or trauma. So maybe your patient has a gunshot wound. Maybe your patient has burns. Maybe your patient had a traumatic brain injury. Maybe your patient got in a really bad car accident and has lots of bone breaks, organ cuts, whatever, like all kinds of crazy stuff can happen. So all of that to say, nutrition is very, very necessary in our patients with critical illness, because of the metabolic changes that are happening in the presence of this trauma and the presence of that inflammation. Not only are we trying to limit the loss of lean body mass, which is a huge marker for somebody recovering from metabolic stress and trauma. But also adequate and appropriate nutrition can help mediate that inflammatory response. If an inflammatory response isn't like appropriately treated, if it's way too heightened for way too long of a period of time, our nutritional status can degrade really, really quickly. And when our nutritional status degrades, it becomes more difficult to heal and recover from these conditions. So what you need to know is that every ICU patient is going to be at risk for malnutrition. A nutrition-focused physical exam, good, strong nutrition assessment really is important in critical care. That can change on a day-to-day, week-to-week basis. And so we have to be really thorough and follow up routinely with our patients in the critical care unit. Oftentimes, nutrition support in the form of enteral or parenteral nutrition is necessary for these patients. At any given time, probably the majority of your patients in the critical care unit are going to be on nutrition support. That's because, one, they may be sedated on ventilator support and they can't eat by mouth. Or two, their nutrition needs are so high that they can't meet their needs through an oral diet. Okay. Generally, we prefer enteral feedings when the gut is functional. Enteral feedings are, one, cheaper, but two, they lead to lesser infectious complications, and also less surgical interventions required after the trauma happens. So not only is enteral nutrition preferred, but early enteral nutrition support is really helpful. And we're talking like the first 24, 48 hours of admit. We want to be initiating and reaching our goal for nutrition support. So you can see how in critical illness, all of our body systems, organs can be impacted, even if the trauma isn't directly related to that organ. Okay, so critical care dietitians have a lot to think about. This is a specialty area that you can receive certification in. You can be a certified critical care dietitian. You can be a certified nutrition support dietitian, if that interests you. If you work at a really big hospital like Our Lady of the Lake or Baton Rouge General, or one in New Orleans, those dietitians are likely, the ones that just work in the critical care unit are likely to have one or both of those certifications, and you might get a little bit higher pay in doing that too. Okay, so there's several things to think about when we have a patient with critical illness. One of those is what happens if we don't feed them. Okay, so this illustration should look familiar. This is from Diet 411, 412. When we talked about the states of metabolism. Okay, are we in a fed state, fasted, starved state, essentially? So in this illustration, we can look at number 4. So anywhere a 4 is appearing, that's sort of what's happening during starvation. So in starvation, we're breaking down adipose tissue to free triglycerides to make glycerol and glucose through gluconeogenesis. We're freeing up free fatty acids from our adipose tissue to create ketone bodies to fuel the brain. Okay. And let's see, what else am I missing? Oh, hello. We are degrading lean body mass to free up amino acids for gluconeogenesis. Okay. So in starvation, we are essentially breaking down adipose tissue. Okay. That's why in the nutrition focused physical exam, we are looking at fat loss. We can also see the breakdown of lean body mass to fuel gluconeogenesis. So the nutrition focused physical exam, we're looking at muscle wasting. Okay. So each of these or both of these are indicators of malnutrition because starvation, right? If we've been in this starvation state for such a long time, we can see physical signs of malnutrition. So when we are in metabolic stress, or if we've had a significant trauma or injury, our body wants to use glucose because at natural times, glucose is our primary fuel source. Okay. But as that glucose availability decreases, we start to lean more on fats. Okay. So we'll first dip into fat, break down fat, that's called lipolysis, free up fatty acids, create ketone bodies. And that itself is that is done in order to preserve lean body mass. Okay. So the longer we are in this starvation mode, okay, the closer we are to starting to degrade lean body mass. Okay. So it's like first is glucose. When we run out of that, we go to fat. And then when we start to run out of that or it becomes less efficient, we'll start to break down lean body mass. Okay. It's really what we want to avoid. So this is just comparing normal nutrition status versus starvation. One of the big adaptations that we see during starvation is that the metabolic rate starts to decrease. Okay. That is significant because if we have a big trauma or injury, we need to be in a state of anabolism, right? We need to be in a state where we can rebuild tissue, where we can recover tissue. But if we are in a starved state, our body works on trying to lower energy expenditure to basically like adapt to less calorie intake. Okay. So if our body is working to adapt by lowering energy expenditure, it's not going to prioritize rebuilding tissue and recovery. All right. As it decreases energy expenditure, the cells are going to require less glucose, and that is what helps them to move towards lipolysis and fatty acid metabolism for energy. And again, that helps to preserve lean body mass. Okay. The longer we're in that starvation mode, though, the more likely we are to start dipping into protein as an energy source. Okay. Does that make sense?
So do their needs change? Like, are their needs lower when they're in the critical care unit, or do you?
It's a good question. So their needs are going to actually be higher. Okay. This is just an adaptation to starvation. So this would happen to anybody. And you don't even have to think about starvation. Like, think about somebody who's cutting calories, like as a method to lose weight. If they cut too many calories too quickly, they're actually messing with their metabolic rate, because our body always like wants to be in homeostasis, right? So if we provide the body with less calories, the body's going to go into this like mode where it wants to preserve what we have, right? So the body adapts by lowering energy expenditure. So at rest, you're burning less energy, or you're burning less calories than you would be if you were well fed. So when we cut too many calories, we can like kind of put ourselves in this metabolic state. Okay.
So when you typically see critically ill patients, how likely is it that they are in a starved state?
That depends on where they were coming from, essentially. So think of like, I'm trying to think, like, say you have a patient who has oropharyngeal cancer, stage 4. They've been in chemo radiation, and they come into the critical care unit with sepsis. Okay, that patient, more likely than not, is going to be malnourished and have been in this starvation state. You're going to treat that patient a little differently in how aggressive you are with the nutrition support because of refeeding syndrome potential, compared to a patient who came in with multiple fractures and a traumatic brain injury from a motor vehicle accident.
So it's more likely that people that come in with freak accidents, like they haven't been in the hospital, that we won't see starvation, but people who've been in the hospital will likely see.
Right. With a chronic condition prior to an acute condition. But like, think about how many people are walking around with these chronic conditions, right? So that's why the nutrition focused physical exam is important. We're not always going to be able to get this like nutrition history from a patient in ICU unless maybe they're not intubated or maybe they have family present. But the starvation thing isn't only a worry for their pre-admit nutrition status, but it's also a consequence of what happens if we aren't aggressive with nutrition therapy once they are critically ill. Okay. So this is a supportive idea for why we need to provide nutrition support to the patients with critical illness and trauma. Okay. Very good questions. Let's see. Okay, so this is just kind of explaining what we just talked about. When we are in this short-term starvation without the presence of injury or stress, we see this energy expenditure decrease. Excuse me. And that can look like a 20 to 25 calories per kilogram per day. So do the math for yourself. How many kilograms are you? And then multiply that by 20 to 25. So, if you were in this starvation mode, you would see that decrease in your energy expenditure. So 20 to 25 of your calories, sorry, of your kilograms. To get your kilograms, you do weight in pounds divided by 2.2. Is that number surprising? Yeah, 20 to 25, that range.
Oh, good, is that number? That's your what?
That's the loss in energy expenditure, the decrease in energy expenditure that you can expect in that starvation mode. So that just speaks to your body's desire to maintain normalcy. Okay. All right. What is the point at which starvation happens?
3 days.
Pretty good estimate, 3 days-ish. It really depends on the amount of glucose that's available. You're essentially in a starvation mode if you're like on this ketogenic diet, right? But you're still providing calories. But 3 days is a good estimate. So think about like if you've ever had a stomach virus, like a 2-day stomach virus as a kid, right? And you just drop weight like that. All right. And in 2 days, you're probably back up to your normal body weight once you're feeling better. And that a lot of that is due to the change in your metabolic needs, your energy expenditure. Because after that 2 days, your body's like, all right, I'm gonna like preserve myself a little bit. And once you start refueling, it's not burning as much at rest. Like you're kind of giving yourself extra because your energy expenditure has decreased. That make sense? Okay. So in starvation, about 90% of our calories are going to come from fat storage. And then less than 10% are going to come from protein because we work to protect lean body mass. Now, in a chronic starvation, that's going to look a little bit different. Okay. Okay. So when we have an acute injury or trauma or critical illness, we see a hypermetabolic catabolic impact on metabolism. So what does that mean in normal people terms? What does hypermetabolic mean? Higher metabolism, increased energy expenditure, okay? Higher energy needs. And what does catabolic mean? Degrading, okay? Catabolic is the opposite of anabolic. We take anabolic steroids to increase body mass. Or I shouldn't say we, some people take anabolic steroids. So when we have this acute injury, acute trauma, critical illness, we see energy expenditure increase, all right? And we see this catabolic impact. Now, think about this. If we have this major trauma, and we're seeing a really significant increase in metabolism, we're in this hypermetabolic catabolic state. And even if we maintained 50 to 75% of our normal energy intake, you see how that creates a gap. So even if we were going to continue with normal status quo of our energy intake, but we have this really high demand, we potentially could be putting ourselves in this starvation phase, okay? So connect that dot. That's why nutrition support is so important, because we have higher needs. We're in this catabolic phase, and we have to close that gap in order to prevent malnutrition, in order to prevent the loss of lean body mass in these patients. Now that hypermetabolic catabolic impact is going to depend on the severity of that patient's trauma. Okay. So if we were looking at a patient who had 10% total body surface area burns and a patient that had 90% total, that person would probably not survive. They would not survive. I should say that. Very big difference in the metabolic impact, right? Our 10%, they're still going to be hypermetabolic. They're still going to be a little catabolic, but nothing compared to that 90% person. Okay. So what happens with stress? Anytime we have an acute trauma injury, that creates stress on the body, stress on the organs, stress on the cells. Again, that can impact hormone release. Hormones are absolutely necessary for normal metabolism. Okay, think about glucose, insulin. We're gonna have upregulated synthesis of acute phase proteins. This is like the inflammatory response. With that, metabolic rate increases. We start to rely more on gluconeogenesis, which means we're breaking down what? That's glycogenolysis. What are we breaking down with gluconeogenesis? We're protein. Thank you. Gluconeogenesis, we are creating glucose from non-glucose sources. Usually alanine, sometimes glutamine. Those are amino acids. So we can see how here in starvation, without injury, without trauma, we are preserving lean body mass. However, when we have this gap in nutrition, making this starvation because we are in this hypermetabolic catabolic state, and we have trauma or injury, it's much more challenging for the body to save lean body mass because this gap has been created. All right. We can also see a shift in fluid balance. We understand now the impact of fluid and electrolyte imbalances on the kidney function, cardiovascular function, all of that. And then that can lead to less urine output. That can lead to kidney damage in a patient. That can impact the recommendations for nutrition support, right? So lots of things can happen when our patients are under this trauma response with metabolic stress. Okay, so one thing for you to understand is that in this trauma response, there's sort of three main phases. There's the ebb, flow, and then recovery. So think of the ebb phase as the shock to the body, okay? So this can happen 2 hours after the trauma injury, or up to 48 hours. So in the first 2 days after a trauma or injury, we're in that ebb phase, which is shock, okay? So what happens is the body tries to like maintain homeostasis. We see hypovolemia, so less blood volume. We see decreased oxygen available to the tissues and decreased cardiac and urinary output. And that all makes sense because if we have less blood volume, we are perfusing the heart less, we are perfusing the kidneys less. And if we aren't pushing as much blood volume, okay, that means less red blood cell, oxygen carrying capacity. Okay. That is called hemodynamic instability. All right. So there can be some challenges to nutrition support when we are providing like a lot of fluid to a patient in the form of nutrition support when a patient is hemodynamically unstable. Okay. So in this ebb phase, in this shock phase, it's really, really important that we are monitoring patients' fluid and electrolyte balance, their renal labs, all of that as a part of our nutrition follow-up. All right, so after the ebb shock phase is the flow phase, and this is where we see catabolism begin. That is because this is when the body like stops being in shock and it's like, oh my God, there's some stuff happening and I gotta like heal. Okay. So what happens is we enter that hypermetabolic catabolic phase. That's the flow phase. Because we are in this hypermetabolic phase, and especially if we aren't closing the nutrition gap, we can see more significant issues with the immune response and hormone response. Okay, so in this flow phase, we can expect patients to have a more challenging time regulating blood sugar. Okay, our inflammatory response is going to be higher. We're going to see higher levels of CRP here. We're going to see higher levels of glucose here. And if we are in that state where we have really high CRP, really high glucose, our body, that's a sign that we are not focused on healing. Okay. So that flow phase can last up to weeks long. Okay. Good nutrition support can play a role in helping a patient get out of this flow phase more quickly. Right. The extent of the flow phase is also going to depend on the extent of the injury or trauma. Okay. All right, and then after the flow phase is the recovery phase, and this is where we see anabolism and a return to our normal metabolic rate. So in the flow phase, the goal is to close the gap. We're not focusing on like really rebuilding tissue at that point. We're focusing on not losing any more. Okay. Once we get the patient stable, the inflammatory markers start to come down. That's whenever we can change to say like, hey, we had some tissue loss. Now we're going to really focus on helping you recover that tissue. Okay. Does that make sense? Now, I've seen research where this recovery phase can actually last like a year. Okay. So it really just depends on what that trauma response was for that patient and how good or adequate the care was. Okay. So it's also important to know nutrition isn't the only player in this. There's been a lot of changes to OT and PT support in critical care for patients. And it's still sort of nutrition related because we know, like, especially in older people or in individuals who have a less anabolic state, we can feed protein all day, but if you're not using the muscle, you're not going to be building or preserving tissue well. Okay, you're not going to be building and preserving lean body mass well. So what good is it for us to provide this like optimized nutrition care if the patient isn't moving at all, right? So in the last 5 to 10 years, there's been a push for particularly like PT to work with patients who are even intubated to get the muscles moving and to really support the maintenance of lean body mass. So dietitians, PT, OT, you're going to see a lot of speech therapists working in a critical care unit are all working to help the patients maintain lean body mass throughout their care.
So is it fair to say that most patients in the ICU will experience some sort of stress and will go through this catabolic phase and we're just there to make it fit?
Yeah.
Right.
Yes. We're taking what we're starting with, right? Like, is this patient malnourished to begin with? Were they in a good nutritional state to begin with? And we're doing our best to like manage essentially the complications and optimize their current nutrition care to help them heal and recover optimally. Once they step down from the critical care unit, that's when like they should have a continued conversation. Like, this is the stuff that happened. Your body needs this and this and this to continue to recover and rebuild the tissue that was lost for you to, like you're very likely to see your patients who have difficulty doing like normal everyday tasks after ICU or critical care unit stay because they've just lost lean body mass. They've lost normal functional status. So PT, OT, nutrition all really help that patient to continue through the recovery phase and regain what was lost.
So our interventions are gonna be different based on every patient.
Yeah,
Because we can have the chronic condition patients that are already in a stress state, so they'll likely be in that catabolic state a little longer than somebody.
Yeah.
who's-
exactly. And on top of that, that patient needs like a refeeding syndrome protocol. And so we can't be as aggressive with reaching a goal rate for that patient, which means they could be in that catabolic phase a little bit longer despite us really trying to push nutrition adequacy. And depending on what that patient's trauma or injury is, specific nutrients can help. So when we looked at the formulary for all of the tube feedings, excuse me, you'll recall that there were like immune modulating formulas. There were formulas that had more like omega-3 fatty acids. There were formulas that had, excuse me, arginine and glutamine to support wound healing or protein metabolism. So depending on that, we can modify nutrition support regimens. We can also provide supplements. That would be particular for like our burn patients. They have a lot of nutrient losses just from the burns on top of the increased needs because of the trauma. And then I'm thinking like for our patients with traumatic brain injuries, there's some good evidence that fatty acid supports, vitamin E support can help those patients recover. So definitely, that's where the critical care guidelines really help you in making those decisions until they become routine. Okay, so let's see. When we are in this fight or flight response to injury or trauma, we have to understand that there's some hormone changes happening. Bless you. And in that flight or fight response, those hormone changes really support hyperglycemia or high blood sugar. Okay, that is because in flight or fight, our glucagon levels increase. We secrete more glucagon to make available more sugar. Okay, fight or flight, the whole goal is to like get out of there quick and fast. So how do we get out of there quick and fast? We provide the fuel to do so. So gluconeogenesis upregulates. But at the same time that glucagon is increased, we also see the increase in cortisol, which is a stress hormone. Cortisol also supports gluconeogenesis. And so we can see how the glucagon supported gluconeogenesis and the cortisol supported gluconeogenesis can both increase blood sugar beyond a desirable level. So that means just from being in this flight or fight response, we're seeing more blood sugar, we're seeing more sugar in the blood, and that can impact healing because hyperglycemia can cause inflammation. Okay, so we have to know as critical care dietitians, this patient's having hyperglycemia because of their stress response. And that hyperglycemia, if I don't help to control that, is going to hinder this patient's recovery. Okay, so we just have to be smart. If we're doing like a TPN for a patient, we would consider this in the amount of dextrose that we provide. Okay. A lot of times these patients are going to be on insulin therapy, even though they may not be diabetic. Okay. That the goal of that is just to decrease the blood sugar. But insulin impacts metabolism, so we don't want to rely on insulin. We want to do the best we can to regulate glucose without exogenous insulin. But insulin is going to be a medical treatment for that patient. So the goal is glucose normalization. It's never going to be perfect in the critical care unit, but we want to be as stable and normal as possible. Also, whenever we have trauma, stress, we can expect to see an increase in acute phase proteins. So stress, tissue damage, and infection all upregulate the action of cytokines. Hopefully that sounds familiar. Cytokines. Cytokines are the little people who tell these acute phase proteins to be made or to do their job. Okay. So cytokines include tumor necrosis factor, TNF, and all these different interleukins. So like IL-6, IL-8, IL-4, IL-2, IL-1. Those are the cytokines that tell interleukins, leukotrienes, interferons, and tumor necrosis factor. Sorry, what am I saying? Those cytokines are what tell fibronectin, CRP, ceruloplasmin, and serum amyloid A to fix the problem. Okay. So inflammation is good and necessary. The inflammatory response is good and necessary. That's one thing that's important to know. So like when you fall and cut your knee or something, your body goes through that inflammatory response. Okay. If we didn't have that inflammatory response, we would be much more susceptible to infection. Like we could die from just dirt getting in our scrape. Okay. But thankfully, we have this really strong inflammatory response that also coincides with our immune response to protect us. All right. The thing that we need to understand is that we're talking about a much more severe inflammatory response in a patient with critical illness. Okay. So instead of having just like a little bit of these cytokines working to make this like tiny little bit of CRP, we're seeing a huge influx of CRP, of fibronectin, of these inflammatory markers. Okay. So we can sort of get an idea of like a patient's condition, where they fall in the ebb flow recovery phase based on CRP. Okay, based on these inflammatory markers. And we have to understand that like until the patient is in a like lesser wild inflammatory response, they're not going to recover. Okay. Medical treatment helps to mediate that inflammatory response, but also nutrition therapy. Okay. Okay, I'm gonna leave it at that. All right. So what we have to understand is that as this inflammatory response happens, as this gap in nutrition exists, gap in energy intake exists in combination with acute stress and trauma, we can see increased loss in lean body mass. Okay, so what are the implications of that? Okay, with just a 10% loss of lean body mass, we can see impaired immune function, okay, and a lower immune system in general. That means we are more susceptible to infection, okay? So here, if we're not providing adequate nutrition support, we're not closing that gap, we are going to see higher rates of infection in our patients who are admitted, okay? That can be an infection directly related to their acute injury or trauma, or it can be an infection that they get in the hospital, okay? A hospital-acquired pneumonia, or an infection to their wound, like a staph infection in their wound, okay? If we're not closing that gap, even if we see just 10% loss in lean body mass, we can see an increased risk of infection, okay? 20% loss of lean body mass means decreased rate of healing, weakness, and infection. Okay, so 20% lean body mass loss, that means we're gonna have a much more challenging time recovering. We're gonna be in that flow phase for a longer period of time. 30% loss of lean body mass, we're more likely to have pressure sores, get pneumonia because we're so weak, we're not moving adequately. We really need to like get the blood pumping and breathe appropriately to avoid pneumonia. Okay. And then we are to the point where we can't heal surgical wounds. We can't heal trauma wounds. And then if we see up to 40% lean body mass loss, we commonly can see death. And that can be directly attributed to the complications from the previous loss of lean body mass. So this loss in lean body mass has to do with nitrogen losses. Nitrogen is the unique component of protein. Okay. Carbohydrates don't have nitrogen, lipids don't have nitrogen. So we can estimate nitrogen intake losses, and that can help us to determine if a patient has adequate protein, but also energy intake. So what this chart is showing us, the graph is showing us, is the comparison with like starvation, just at baseline, like no trauma, no injury. The amount of protein, nitrogen that's going to be lost and over what period of time compared to like a major burn. Okay. Burns are like the highest hypermetabolic situation that a person is going to be in. Okay. The greater the surface area of the burns, the more hypermetabolic catabolic state that they're going to be in. But even a major surgery that's uncomplicated can lead to this nitrogen excretion and loss of lean body mass. And so there is a role for nutrition support in all of these types of patients. But really, with burns, like there is really, really significant impact in nutrition support. Okay. So when we have stress and trauma, we see that catabolic adaptation can lead to protein energy malnutrition specifically, because now we are reducing lean body mass to provide fuel for energy. And that means that the protein that we consume isn't going to be used to heal. It's going to be used for an energy source. So with this, we're going to see higher metabolic rates. We're going to see increase in glucose production and an increase in protein for fuel. So in the presence of protein energy malnutrition, we can't use protein to maintain lean body mass. It's essentially going to be used to support calorie intake. So to treat this, the patient needs adequate calories, okay, for protein sparing. Protein sparing means that the patient is adequately nourished with calories in order for protein to be able to do what it's intended to do, aka preserve lean body mass and heal. So an example is if a patient's needs were like 2,500 calories and 100 grams of protein, and I was providing 2,000 calories and 100 grams of protein, yeah, I'm meeting their protein needs, but that protein isn't going to do the job of protein because I have this gap in energy intake. Okay. Does that make sense? All right. So to summarize all of that, is it time to be done? Hold on, I have a message. Here. All right, so higher, when we have this trauma response, this acute response to injury, more glucagon, cortisol, epinephrine, norepinephrine, our fight or flight response means hyperglycemia. Okay. Hyperglycemia in the presence of trauma, injury promotes insulin resistance. In that combination, hyperglycemia and insulin resistance impacts our inflammatory response and basically makes healing more difficult. It makes recovery more difficult. So one of the goals of nutrition support, normalizing blood sugar, insulin sensitivity, so that the body can focus on healing. We also see increase in metabolic rate, which means we rely more on gluconeogenesis, which means that we can see the catabolism of skeletal muscle, aka the loss of lean body mass. So nutrition support focuses on normalizing blood sugar, but also maintaining lean body mass. Okay. And just to bring it back to all of these body systems, we can see really systemic impact from trauma and injury. So we just have to think about all these and understand the supportive role of nutrition support for these patients to close the gap in energy needs and energy intake. All right, so when a patient has metabolic stress, they're critically ill. We basically want to balance preventing malnutrition and creating more complications. Okay, so the scenario that we talked about, the patient with at risk for refeeding syndrome, that's an example of where we have to balance this malnutrition with complications. Okay, so instead of saying, oh my gosh, this patient's malnourished, they're here for trauma, we have to feed them and feed them fast, we got to nourish them. Dietitians say, I know the metabolic consequences of this patient being in starvation mode. I know that if I feed them too quickly, we're going to see severe fluid and electrolyte imbalances that can cause cardiac arrhythmias, that can cause breathing irregularities, which means it's going to be harder for that patient to come off the vent. It's going to be harder to get that patient hemodynamically stable. And so, yeah, our goal is to provide adequate, optimal nutrition support, but we have to get there carefully. Okay. There's lots of those sort of scenarios. I think the refeeding one is just helpful. But all of that to say, dietitians have to understand as best as possible what was this patient's nutritional status prior. Okay, do an NFPE, understand the severity of the patient's injury. We're going to treat a patient with 10% body surface area burns differently than we treat a patient with 60%. And we just have to understand what state of that ebb flow recovery phase that they're in. Understand the role of the inflammatory response and how we can provide nutrition support to mediate it and reduce the negative consequences of those metabolic impacts. So next class, we'll take a look at the critical care guidelines again. I encourage you to open it. I'll make sure that they're added in this module. But you can, it's a very long document, but you can do a control F and you can see refeeding syndrome, you can see acute pancreatitis, you can see traumatic brain injury, if you wanted to look at those different things. And it provides very clear care guidelines for specific conditions. I think we pretty much talked about each of these things for metabolic stress, so you can take a look at that separately. Okay, any questions about overall metabolic stress and trauma? Bless you. Okay. So now we'll talk about some specific conditions. sepsis and systemic inflammatory response syndrome, that should be syndrome, not system, or SIRS, are two of our most common infection inflammatory related diagnoses for patients in critical care. We know that these can happen often after surgery or specific trauma. So a patient can come from like a major accident, like a motor vehicle accident, and they can develop SIRS or they can develop sepsis. But basically we know that it can cause accelerated release of those cytokines that upregulate the inflammatory response. We can see higher impact from those metabolic changes that happen with critical illness and metabolic stress. And overall, with the like signature sign of sepsis and SIRS is hypovolemia, which leads to hypoperfusion of the organs. Okay, so the kidneys are getting less blood volume, that leads to kidney failure. The liver gets less blood volume, that leads to liver failure. Okay, and hypotension. So one of the ways that we diagnose, or that a doctor would diagnose sepsis, is like we're starting to see significant alteration in kidney function. They're hypotensive, and their white blood cell counts like through the roof. So we have an infection present, and then we're seeing systemic impact. So the kidneys aren't working as well, and we're seeing hypovolemia, hypotension. So what started as like a localized infection has led to this systemic inflammatory response that's like sort of out of the guidelines for like what that response should be for that small and localized infection, if that makes sense. Okay. Okay, so increased white blood cell count, hypovolemia, which can look like low blood pressure with accompanied high heart rate. So it's like kind of counterintuitive. With that, the patient might have higher respirations, and then with the infection, fever is common. So as far as medical treatment, the medical team is gonna treat the source. That's gonna look like antibiotics. The patient may need to be intubated and put on a ventilator if breathing is that affected. And the goal is to achieve hemodynamic stability. So they're going to provide probably IV fluids to increase blood volume, and then medications to help control blood pressure, essentially. The fluid provided through IVs is also going to help with the perfusion of the organs, which are seeing reduced function because of the hypoperfusion. All right, so the goal for nutrition is to identify these metabolic abnormalities that we see in metabolic stress, provide adequate nutrition to support the patient through that, but also not add to the complications of the hemodynamic instability. So basically, if the medical team is still trying to stabilize that person, we don't want to like go full blast on a tube feeding or TPN because they're already getting this added volume. So we just have to be careful with how aggressive we are for those patients. This is just an acronym to identify sepsis. This is from the Sepsis Alliance. Temperature, infection, mental decline, and extremely ill. So it is time to go to the hospital. Any questions about sepsis? I think we'll stop after burns. Okay, burns. The impact of burns and the treatment of burns is gonna depend on two major factors. What type of burn or what caused the burn, and then two, the extent of the burn. So for example, there could be burns from chemical exposure. So like a plant, if there was an accident at a plant, that could be a type of chemical burn. We can have burns from radiation. And even that like a smaller, lower level, like a patient who's getting like radiation for head and neck cancer, they actually can have burns. But when we're thinking about trauma, we're thinking more of like a deeper type of burn. Or they can be electrical burns. Now, the doctors who work in the like on a burn unit and see burns more often, they're gonna understand the different impact on the layers of the skin, based on those different burn types. So a dietitian too that works with burns is gonna understand that a little bit more as well. So essentially with burns, we have to understand that whenever we lose skin integrity, not only are we in this hypermetabolic catabolic state because we have experienced an acute trauma or stress to the body, but whenever we lose skin, we see losses through the skin, losses of fluid, losses of electrolytes, losses of nutrients, losses of protein. Okay, so stress is heightened, which affects metabolic status, metabolic rate, but also we're seeing these losses from the wound. So there can be some challenges in meeting a patient's needs with a burn. The rule of nines is used to estimate body surface area. So each like section of the body is considered to be about 9% of the body surface area. So if you look at this, like the upper chest torso area is 9, lower torso area is 9, the front of the leg is 9, the back of the leg is 9, the lower back is 9, upper back 9, and then together the arms are 9, front and back. Okay. So dietitians have to identify, we're not the ones estimating the body surface area, the doctor would clearly write that in the notes, but the dietitian has to account for the percentage of body surface area in the burns whenever they're estimating a patient's nutrition needs, their energy needs, their protein needs, also their vitamin and mineral needs. So there's different layers of the skin, and depending how deep the burns are is going to impact the patient's nutritional needs as well. The medical treatment for burns is tricky. One, because of all of the losses, so it can be hard to maintain adequate fluid and electrolyte balance in these patients, which can lead to other organ dysfunction. And then sometimes patients might require skin grafting. Sometimes they require, most of the time they're going to require some type of debridement, and on what schedule it depends on the severity of it. But debridement can be really, really painful for patients. So just think like if you've ever had a very small burn on your hand or something, think about a patient. You can just like have some empathy for a patient who has 20 or 30% body surface area burns, how much pain that they would be in. And so they're going to be on pain medications. They're going to sometimes be on a ventilator to help maintain respiration, but also they just may be sedated because it's so bad. So patients with burns are at a high risk for poor nutrition status because of that hypermetabolic catabolic response combined with the losses that we can see through the wounds. So up to 20% of lean body mass can be lost within the first 2 weeks after burns. And that's going to depend on the severity, the extent of the burns. But fluid imbalance, pain, and mobility all can play into a patient's nutritional status. And also like as burns heal too, the skin like tightens and it can just make it really difficult for patients to continue being mobile, even if we've optimized nutritional status. So one of the things that a dietitian working with burn patients will do is really read through the wound care nurse's notes, and get a good understanding of how well these wounds are healing. Are we seeing dehiscence, meaning that the wound is getting deeper and like kind of wider instead of closing up? How much loss are we seeing from the burns? Those are things that could be noted in a wound care nurse's notes. And that just plays into our interpretation of the patient's nutrition needs. Okay. So as far as nutrition support, we want to optimize nutrition intake. Okay. Oftentimes, this is going to require nutrition support through enteral nutrition. Our rule of thumb is that if a patient is consuming about 60% of their energy needs, we start weaning from nutrition support because we want the patient to eat by mouth as soon as possible. We just need to make sure it's adequate. So for our patients with wounds who are on an oral diet, we really need to lean on nutrient dense, calorically dense, protein dense oral nutrition supplements to close the gap. That also provides some fluid and vitamins and minerals. We really need and want to optimize glycemic control in our patients with wounds. You will have an epic time trying to heal any type of wound when blood sugar is high, okay, and uncontrolled. So the patient's going to likely be on some insulin therapy, but you are doing your best to optimize glycemic control through your nutrition support. The formulas that the patients with burns are going to be on are going to be a very high protein immune modulating formula. So it's going to be a lower concentration of carbohydrates anyway. Okay. As far as nutrition supplementation goes, there are 5 essential amino acids, vitamins, and minerals that are essential to a patient with burns. One is glutamine. That's an amino acid that really helps to rebuild tissue. Zinc and vitamin C work together to rebuild tissue in wounds. Selenium as well. This is also an antioxidant. So it really helps to reduce damage, like the free radical damage that's happening within the tissue. And then vitamin E is an important fat-soluble vitamin for rebuilding tissue and for just skin integrity in general. It's also an antioxidant. So those are important for you to remember. I don't think it's that important for you to know like the specific amounts of these vitamins and minerals and amino acids at this point. But knowing which ones are essential to a micronutrient regimen for a patient with burns is important. How can this be provided? There's different oral supplements that can be used. One of those is Juven. This is a little bit controversial. Juven is, it's like a little powder. Oh, no, not juvenile. It's a powder that can be mixed into water. Most patients like it. It has arginine and glutamine, and it's meant to support wound healing. I think it also has vitamin C. It's got collagen, zinc, vitamin C, E, and B12. So basically, all of the things that we listed here are included in Juven. The challenge with Juven is that it is a pretty high cost. I would have to look and see, but a typical regimen for Juven is to have one of these twice a day. I think it's like $15-ish or something for a box. And it comes in like, let me see. Let's look. $25 for a box of 8. So it's very expensive. Yeah. It's very expensive. And okay, the controversial thing in the Juven is the arginine. So there's some research about arginine, particularly in a patient who's hemodynamically unstable. Whenever we provide higher doses of arginine, which helps with vasodilation. If we have a patient who's already got hypotension and we're promoting vasodilation, it can cause more hypotension. So the thought is to provide like a Juven with arginine when a patient is hemodynamically stable versus in like the ebb early flow phase. Okay.
Could that over time, if not caught, lead to sepsis because you're having a decreased blood flow?
That's the connection with the arginine is the sepsis. So the research was like we could potentially see higher in incidence of sepsis if we use this. So maybe next week we can look at what that research is saying these days. But there's a connection with that for sure. So yeah, the HMB protein, I forget what the abbreviation stands for. I have to look at it again. But there's a lot of research about this protein complex in supporting lean body mass maintenance, especially in patients with cancer. So I've even seen dietitians recommend this for patients with cancer because of that. If they're meeting calorie and protein needs already, we can provide the supplement to really support maintenance of lean body mass. But if they're not getting adequate calories and protein, it's not gonna help. Yeah, like it's literally a waste. Yeah. For that patient, a much better supplement would be like an Ensure or something that's providing calories and protein, not just like a protein modular. Okay, any questions? We'll stop there and take our break. Do y'all think this is interesting? Yeah, critical care is interesting. Okay. All right.